So foot and ankle physical exam is something that should be quick and easy, honestly. Should take you maybe 1 to 2 minutes to do a really good, thorough exam, which is the nice part about it. So for most of my patients, when they come in, this is how I see them in the clinic, and I encourage you to do the same, which is have them sitting on an elevated spot if you have it, if you have that ability, with both their shoes and socks off. It's always good to see, usually people are coming in for one side, but it's always good to test kind of the side that is less affected. So, you know, I'm gonna get down here just to kind of look, and hopefully we're getting a good shot of the screen. Good. So the first thing I'll always do is I'll just look at their foot. You know, for someone who's like CRPS, you're seeing, are they really red? Is there any swelling? Is there any bruising? And then I will pick up both feet to make sure that I look at the bottom. Because one thing you can see on the bottom is you can see callus formations. People that have metatarsalgia, problems with pain in their toes, they'll often have, you know, direct callus formation. And the bottom of the foot tells you where people are loading their foot, because you develop calluses where you are abnormally loading your foot. So people that have a lot of calluses on the outside, people that have calluses over here on the bunion, it'll tell you kind of where you're abnormally loading. And so the next thing I'll typically do is I will just look for pulses. And so you're putting DP and posterior tib, usually at the same time. And I will do a quick neuro exam too, and I'll just ask sensory exam. Feel me touching you here? Which is deep perineal here, just right at the base of third for superficial perineal. I'll go along the medial malleolus for saphenous, along the base of the fifth for sural, and then on the bottom of the foot, I'll do both medial plantar and lateral plantar. Because you want to just know, I kind of just want to know generally off the bat, is this person a neuropathic or not? If there's any kind of question, I will get my Semmes-Weinstein out and actually do a monofilament exam. But for most people, if their normal sensory exam is there, I can kind of go with the rest of it. And so the next thing I'll do is I'll have people with both sides, I'll have them just pick your foot up towards yourself, like this, good, and push down, good, pull in, good, and pull out, good. And I've learned that if you just talk to people about what to do, they'll never be able to do it. So you have to demonstrate with your hands kind of what to do, and people can follow you pretty well. And what you're doing here, what am I looking at? Well, you're looking at range of motion of the ankle joints and the hind foot joints. So as you pull up again, Kristen, great. This is your tibio-talar joint, and push down, also your tibio-talar joint. Pull in, this is both your subtalar and your talonavicular joint. Pull out, again, subtalar and talonavicular joint. And you're also looking at tibialis anterior, tibialis posterior, peroneus brevis, and a little bit of peroneus longus. And these are the big kind of muscles that help give balance to the foot, and you want to see if they're working really, really well. And so the next part that I'll have people do, go ahead and stand up, is I'll have people stand up, and I can't demonstrate here. I will look at them from the front, and then, mind turning around, Kristen? You should face this way if you can. And look at them from the back. And so this is where you're really observing, do they have a flat foot? Do they have a high arch? What's normal? And normal for people, if you follow the line of their Achilles down, it will usually make a little bit of a slight valgus bend of about 3 to 5 degrees. Kristen's in slight valgus to almost neutral, which is still normal. And then you want to look and see, you know, what's a normal arch. A normal arch is usually you can put it about 2 fingers in. And the next thing I'll have people do is, can you get up on your toes? So as they pull up on their toes, what you can see here is normal will be pulling the heel into varus a little bit. When you pull the heel into varus, it locks your hind foot and allows you to kind of create a stable platform to go up. So a varus foot is a stiff foot. That's what it's going to be. You stand back down again. And a valgus foot is a supple foot. So when you're standing, you want it in slight valgus to be a little bit supple. And as you go up on your toes, as you toe off to walk, you want it to be in a little bit of varus. So patients who have tibialis posterior insufficiency, people that have pathologic flat foot, cannot do this. When they try to go up on their toes, they will not be able to kind of pull their heel into varus, and that's kind of one of those signs of pathology. So you want to see what they do. And then I'll also have them kind of walk a little bit. So Kristen, you wouldn't mind just walking. And then back here. Because there are some things that are dynamic in nature that aren't exactly static. And so you want to see, do they have a normal heel progression? Are they raising their toes up? Is there any tendon that isn't necessarily firing? Any kind of dynamic varus or valgus that happens? Have a seat up here. And the last thing I do, after you do good kind of basic stuff, is I'll just say, where are you having pain? Point to where it is. And so I have people physically point to that one spot of pain they have. And again, it's something that where if you do the tenderness at the start of the exam, then they may be a little reticent or painful to do the other things. The other thing that happens too, honestly, is that sometimes you need to provoke them a little bit into feeling where the pain is. So by getting them to stand up, do all these movements, walk around, sometimes it'll kind of spark that pain a little bit and they can say, yeah, it's right here. And so then I will actually, physically go through and make sure that I'm palpating exactly where their pain is. And that ends up being kind of your very basic foot and ankle exam that I do on everyone. And then I go through kind of the specialty tests. So these are the specialty tests for you guys to know and to practice. The first one ends up being for patients that have ankle instability. The ATFL runs from this part of the fibula, the very most distal anterior aspect, onto the talar neck right here. So in order to test, it's very similar to an anterior drawer in the knee or a Lockman. And what you're doing is you are plantar flexing the foot about 15 to 20 degrees. Here, let me do left side. Let me make this a little bit here. So the tendon runs right here. It's on, or ligament rather, sorry. It's on maximal stretch being slightly plantar flexed and inverted. And so you're securing the tibia with one hand. I like to have my thumb over the talus and my two fingers on the calcaneus, and then what you're doing is you're trying to anterior translate the foot. And this is called an anterior drawer. And you can see just ever so slight give there. And so with people who have 2 feet, it's great because some people are more ligamentously lax than others, and you want to see, okay, what's normal for them. It's not what's normal for everyone. And if you do it more and more, you get a kind of a sense. And this is a very subtle physical exam finding, and so it's something that you kind of have to do a lot before you get a real sense of what looseness is. But what looseness will be, and I tell my residents, it's like if you ever really kind of want to understand it, put your 2 thumbs together and move. If your thumbs aren't separating, there isn't much there. If your thumbs are coming apart, then you have a decent amount of looseness in that ankle. And that's in their ATFL. So this is when we talked about that ligament that's most commonly sprained. This is what you're checking. And for people that have chronic instability, chronic pain in that area, that's what you want to evaluate. And then if you want to test the CFL, it's the same thing. In this one, you put them in neutral, and then you try and invert their heel. And again, that calc fib ligament going from the calcaneus to the fibula, deep to the perineals. So you're pulling them in to see kind of how that works. And so the people that have chronic instability, really bad sprains, this is what you are testing. For the high ankle sprains, for those syndesmosis sprains, how do you evaluate that? A few ways to do it. One way that I like to do it first is I'll secure their ankle, and I'll give them what we call a dorsiflexion and external rotation stress. So kind of secure their ankle, their knee up top, and try and externally rotate their ankle. A positive test here is if that's painful. And painful down here, kind of where the syndesmosis would be. The best test, and probably the most sensitive test, is what's called a squeeze test. So in a squeeze test, you secure their foot down low, and I will squeeze between their fibula. You can find the lateral aspect of their fibula up top. If you go up top too high at the fibular head, you will get the perineal nerve, common perineal nerve right there. So you're a little lower, and you just literally squeeze the 2 bones together. And what you're doing here is you're stressing the interosseous ligament. The interosseous ligament runs in between the tibia and the fibula all the way up to the knee. So by squeezing up top, a positive test here is that hurts, it shoots pain down into my ankle. If it's painful where you're pressing, then you're maybe just pressing too hard. But pain that goes down into the ankle is a positive test for a syndesmosis injury. And so if you're concerned about a high ankle sprain or a syndesmosis injury, these are the 2 tests that you should do. The other one that you can kind of do, it's a little tough for a lot of people to do, and it's the same thing as the dorsiflexion and external rotation, is you get people in figure 4 and you do that dorsiflexion external rotation. This is what's called the cross-leg test. Same type of thing where people will have pain there if their syndesmosis is injured. The other specialty test that I don't do on everyone, but people who have pain, you know, I will actually examine their first toe. Obviously asked about hallux rigidus and arthritis of the first toe. And you do want to see kind of how much motion is in the toe. And the other thing that I'll end up doing for people that maybe have instability of that toe is you'll do an anterior shuck. It's just an anterior drawer of the toe. And we didn't talk about plantar plate injuries, but you do have areas of tissue underneath all 5 of the toes, and they can get injured and sometimes torn, and sometimes that can contribute to crossover toes and hammer toes. And so by testing, you can actually test that plantar plate to see its integrity or not. And you'd be surprised, you get some people that are ligament too lax, and you can just almost translate their toe completely, and that can lead to shearing forces on the cartilage and pain in that regard. And the other big specialty test to do is for the Achilles. So first thing I like to, if people are able, I have people actually lie on their stomach. And this is actually the best test for a chronic Achilles. So what you can see here, hopefully, is that this is normal resting tone. Normal resting tone is about 20 degrees of plantar flexion of the foot. People that have an Achilles rupture, gravity will pull one down. And so you'll have a loss, we call a loss of resting tone, to where the normal side over here is slightly plantar flexed, and the abnormal side where the Achilles rupture is usually at about neutral or so. This is what's crucial for people that have chronic ruptures, because what the chronic rupture will tell you, if they haven't been seen or something else, if they have an abnormal resting tone, it means that it healed, but it healed in an elongated position. So anyone who healed in an elongated position, these are the people that come in with pain, weakness. They say, yeah, I felt the pop 6 months ago. Their Thompson test is kind of equivocal because they do have fibers that are attached, but their resting tone is off, and that's why, so you have to do both. So the resting tone will be off. You can literally feel the Achilles. I will, even for people, I will put the Achilles on stretch. You can really feel the tension of that tendon, feel if there's any defect. And then the old glorious Thompson test. So if you'll see here, as you plantar flex, or as you squeeze the calf, there will be plantar flexion. Hey, Kristen, can you try and resist this? Just try and resist, just to hold your foot. No, just hold it, just try and hold it there. Yeah, I still can't do it. That's what makes this test great. It's really hard, it's completely involuntary, and it's completely pathognomonic and better than an MRI. And so the reason that Achilles ruptures get missed is because people that go in the ED and urgent care, you're always facing your patient, you're looking at him in the chair, and you just don't do this. But obviously this takes all of about 30 seconds, and that's why my harp on it. Sorry to get on my soapbox some more, but you really, acute Achilles rupture shouldn't be missed because it's just so easy to do. So again, you know, you can palpate, find if there's a defect, you can look at resting tone, see if it's the other side, and then just the squeeze to see if that Achilles is really working. And that's the foot and ankle exam. It's thankfully relatively quick. Doing a good exam should take you 90 seconds. So you want to check alignment, you want to check tendons, you want to check range of motion. You want to really spend a lot of time, and probably the majority of my time I spend with patients is using my thumb to try and pinpoint where exactly they're having pain, because that can really help you find out what's going on, really dictate treatment and things like that.